Hi, Mike Gibson, Greg Stone, joining you to talk about the Protect 4 trial, looking at people with severe coronary artery disease with left ventricular dysfunction. Greg, a lot of debate about there. Do you put an Impella in first and proceed with your revascularization, or do you wait until something goes wrong and then put the Impella in, something that I call Impella regret? But you're doing a trial to answer this question, looking at the benefits of Impella in this scenario. Talk to us a little bit about the Protect 4 trial.
Well, thanks, Mike. It's really surprising. PCI is really spreading now to more and more complex and high-risk patients. And there's seemingly very little that we can't do in the cath lab. And when we talk about the patient with CHIP, complex high-risk indicated patient, we're talking about patients that have usually multiple clinical comorbidities, two very complex coronary disease, maybe left main, maybe calcified lesions requiring rotational or other types of atherectomy, chronic total occlusions, et cetera. And typically and classically a patient with severe left ventricular dysfunction, and or hypotension, right ventricular failure, et cetera. And when you have those three overlapping domains, you really have the classic CHIP patient. The question really has been, when you do high-risk PCI in those patients, many of whom are contraindicated for or have been turned down for bypass surgery, they often have high syntax scores, et cetera. Can they benefit from prophylactic mechanical circulatory support, whether it be a balloon pump or an Impella type transaxial flow device or ECMO? And there's only been one, really large randomized trial. And that was, Holger Thiel's trial, the BESIS 2 trial, with 300 patients, with such patients randomized to a balloon pump versus no balloon pump. And there was no difference in the primary endpoint of early in-hospital complications and survival. Interestingly, though, in a non-powered and non-pre-specified endpoint, 5-year mortality was reduced in the balloon pump arm. But that wasn't really explained well because the extent of revascularization was the same, and people don't know whether that was a real finding or not. So when you look at the guidelines in the US give a very tepid class 2B recommendation for any kind of a prophylactic or elective mechanical circulatory support for high-risk complex PCI. And then it doesn't differentiate between a balloon pump or other types of support. Whereas the European guidelines, to my knowledge, have never even mentioned this concept. It doesn't give any guidance whatsoever. And that just shows you the paucity of the data. So there was one other randomized trial called Protect 2 in the United States. And this was a trial of the Impella versus balloon pump in very high-risk complex patients. But the trial was actually stopped early because of futility. And they had a very odd composite endpoint, which used a very sensitive definition of periprocedural myocardial infarction, which actually dominated the endpoint. Despite that, when you looked at the 90-day outcomes in the per protocol data set, it was actually positive for Impella. But obviously, it was overall a negative randomized trial. So this led us to design the Protect 4 trial, which is going to be by far, I humbly believe, the most comprehensive study to ever really tackle this issue. And what we're doing in Protect 4 is we're taking 1,252 patients with both left ventricular dysfunction. They all have to have an ejection fraction of less than 40%, and very complex coronary disease. And they're being randomized to undergo PCI with either standard support, which can be, again, either no support or a balloon pump, according to operator discretion, or with an Impella CP device. And there's no crossover allowed between the two arms. And if patients get ill in either arm, the most common escalation pathway will be to ECMO, perhaps tandem heart, but mostly ECMO in both groups. And our primary endpoint is actually a composited 3-year follow-up. So this is not just an acute study. And our hypothesis is that by affording hemodynamic stability, you're going to get rid of the rushing aspect of the trial, of the study, and it's going to allow you to do PCI with more intravascular imaging and more careful lesion selection and more stent optimization. You'll be more likely to get complete revascularization, and it will improve not only the early safety of the procedure, but also long-term outcomes, better left ventricular function recovery, fewer long-term arrhythmias, less hospitalizations, not only from restenosis and stent thrombosis, but also, again, because of less heart failure. So our primary endpoint is a composite of all-cause mortality or need for LVAD or transplant, myocardial infarction, stroke, or rehospitalization for any cardiovascular cause. And that's over at 3 years. And we believe at 1,252 patients, we're powered to show this.
Well, that's 4 times more patients than Holger Thiel studied previously. So getting up to a sample size where we may see some meaningful differences that are adequately powered, as you say, Greg. Well, congratulations. Glad to see, again, you're trying to answer the question more definitively with a randomized trial. Good luck. Thanks for joining us here today, and thanks to all of you for joining us here at Snackable Health.